Okay. All right. So sounds good?
Yep.
All right. Okay. Good morning, everyone in the audience, both physically and virtually. Today, we are talking about one of the most important and very difficult to treat symptoms in Parkinson's, which is sleep problem. And I show in a slide that there are different kind of the sleep problem. Let's say when you come to see me or any doctors and say, okay, I have a problem sleeping. There's so many things, right? It can be from many reasons, and we have to figure it out. Not like, okay, we'll give you Ambien, we'll give you clonazepam. So we have to look for the cause, and we try to take care of that cause, okay? So usually what we want first from you is, if you have a problem with sleep, is that problem to start to sleep, initiate sleep, or a problem with maintaining sleep, okay? Or sometimes we have both, okay? We'll read the next slide. So I put in general, it may be more than this, but I just give you a general sense that it can be a variety of things that can cause it. For example, if you had a wearing off at the end of the day at night, or in the middle of the night, that can interfere with your sleep, because then you cannot toss and turn, you have pain from the off pain, you have a stiffness, you want to turn here or turn there, you cannot maintain the position in bed properly, then it can cause a problem with sleeping. It can be anxiety and your mind thinking everything, things gonna happen, what we're gonna do next and things like that, that can interfere with the sleep. And then vivid dreams, or some people acting out the dreams, that can sometimes may not wake you up, sometimes wake you up, and that can interfere with your sleep. Or you have a hallucination, so or delusion, you get up in the middle of the night and then you see something, you get scared, you cannot fall asleep, you worry about it. That can happen as well. Or you had a restless leg, then you cannot fall asleep because your legs feel uncomfortable, bubbly feeling, burning, tingling, and you need to move around. So those are the thing. And then, or if you have a bad hygiene, in terms of sleep hygiene, or you sleep a lot during the day and you cannot sleep at night, or you drink too much coffee, or you drink too much alcohol and things like that. So those are the things that can affect the sleep problem, a sleep quality, and we have to see what is it, and then we try to fix it. So it will be or you have to get up in the middle of the night to go to the bathroom, urinate. That can be a problem too, right? So maybe you could perfectly good, and then you wake up in the middle of the night, have to go to bed, and now cannot fall back to sleep. That's a problem. And sometimes not just one time, sometimes you wake up 2 or 3 times to go to the bathroom. And this is something that I want to ask Dr. Izzo to talk later too, that one time, I talked to one of my colleagues, a nephrologist colleague, and then I told him that, oh, you know what, my patient wake up in the middle of the night because they have to go to bathroom. And he said, you know what, that is not the main reason. The main reason is that particular patient already waking up a little bit, like lighter sleep, and then the bladder reflex come back. Because if you completely deep sleep, even though your bladder is full, completely full, you have no feeling of a thing. But if you just go a little bit awake a little bit, but not awake, but just lighter sleep, then the reflex coming back and then make you wake up.
It's true.
So that she confirmed it. Okay, good, thank you. So, okay, the next slide. So that's why I'm saying, okay, first we have to look for the cause, right? I put in S because it can be many. And then we have to fix it. And then a good sleep hygiene is very important. And then at the last resource will be the sleep medicines, which Dr. Izzo will give a talk in more detail. All right, next slide. Okay, so I just show again what the cause, right? And go to next slide. I'm gonna talk to some of them that I can handle myself. For example, the first one is wearing off. That is something that we've been working with you all the time. I think most of you, we talk about this every time. How long does it take to levodopa to kick in? How long did it last? And And how do you feel at night, and you feel difficulty to turn or not, or getting up and things like that. So those are the things that I can handle. So, so if that is the reason, then we have to adjust the medicine. For example, someone who has not been taking carbidopa, levodopa, extend release yet, then we add it at night. The problem with the extend release is that it's longer, but not very long. So it may still be very short, and then you may have to take another one in the middle of the night. And different individual is completely different. So we have to talk about it, adjust it, and work together. Or if it's someone who can take the dopamine agonist, means that this is the medicine that is not the dopamine itself, but it works similar to dopamine. We call dopamine agonist. And I like to use analogy between the sugar and a sweetener. Sugar is the real sugar, right? Sweet. A sweetener is not the real sugar, but still give you a sense of taste of sweetness, right? So the same thing. Levodopa, carbidopa, levodopa, it will go to the brain and turn into dopamine. So it's a real thing. It's a sugar. But dopamine agonist is mean that it's a chemical. They make it up to make it have not a real, like so that's an analogy. And the good thing about dopamine agonist, the agonist that is the extended release is going to be even long, which is the 24 hours, is a patch. That's the best. The problem is the price, and it's difficult. And DBS or duopa is more like a surgical technique to make it smooth. For duopa, it's the intestinal gel infusion of levodopa, but you have to get the a tube feeding look to put into the stomach through, and then the tip will be at the small bowel, at the jejunum, and it will deliver as more continuous. But if you want it to help with the sleep, then it means that you have to carry around the pump at night too. So usually nowadays we use it more for the daytime. I have a few patients that need at nighttime, but we will talk about this, about the surgical options in Parkinson later in more detail. Okay, and the DBS, I think everyone know about DBS, right? Everyone know about DBS? Yeah, it's a deep brain stimulation. Put the X maker, we can adjust it and make it. Okay, so anxiety, that is something that I can or cannot, depends on the situation, because I'm not a psychiatrist, so I still need to help. But if it's something easy, then I can try to do it. If anxiety coming from the wearing off, sometimes dopamine wearing off can cause anxiety too, then we adjust the dopamine, okay? Now, if it's not related to the up and down on the levodopa cycle, then we have to treat the anxiety, and there are so many ways of doing it with the medication or not medication, relaxation technique, massage, therapy, and then medications. And so I always want to put the medication as the last resource. The medication, some of them is the antidepressant, which can be used for anti-anxiety as well. And sometimes we use the more like short-acting, like clonazepam, Ativan, as needed, which we want to try to kind of stay away from it, because clonazepam, Ativan, Xanax, although it's very good for anxiety, it's short-acting and it's not for a long term, and it can cause a balance problem. So usually we use those kind of things for like in the meantime while we figure out something else, but we don't want it to be a long term, and it can cause addiction too. So that's not a good thing. And what else? Yep. So next one. Okay. Now this is the rapid eye movement behavior disorders. We call it REM sleep behavior disorders. So basically, when this is Dr. Izzo will talk in more detail. Just to touch base, just a quickie. So basically, when you're sleeping, you may see that you move or acting out the dreams. Normally when you are dreaming in a REM in rapid eye movement. Let me go back a little bit. When you sleep, you had a non-REM and REM sleep, right? And the REM is the one that your eyes going to keep doing that, and that is the time when you have a lot of dream at that time. But our body, our brain, try to protect ourselves so that we don't act out the dreams. So usually at that moment in a REM sleep stage, you're supposed not to be able to move. You should be like paralyzed for a little bit. But you can dream about it, you cannot move. That is our protection. But in this REM behavior, common in Parkinson and related disorders, that mechanism can move at the same time. So you can be like someone next to you and kicking. So those are the things. And the treatment that I know is clonazepam, and sometimes we can use melatonin. But then I want Dr. Iso to talk more about that. Okay. And okay, next slide. And hallucination, delusion. So this is something that can interfere with your life when sleeping as well. So the treatment, again, we talk about something that's not medication and something with the medication. And we want to make sure that environment is good, relaxing, cool, and keep routine that will help with to avoid any hallucination or agitation at night. But if the medicines, if non-medication approach doesn't work, then we have to use the medicines. And there's unfortunately antipsychotics, means the medicine to treat the hallucination and delusion. Most of them, like 90% of them, gonna worsen the Parkinson because it blocked the dopamine. So, but the one that will not do that is the quetiapine, which is a generic name, and Seroquel is a brand name. That one will not block the dopamine. That's why you will see that I usually use that as a first step. And then another one which is newer, but been around for a few years now, called Nuplazid. And that is another antipsychotic. Actually, that's only the antipsychotic that FDA approved specifically for Parkinson-related psychosis. Okay, but Nuplazid is not going to work right away. You have to take it, and you have to wait for 2 to 6 weeks to work. So it's a drawback. The quetiapine, we can do it right away. So sometimes I use the quetiapine first, and then while waiting for Nuplazid to work, and then stop the Seroquel. So there's a lot of things. Or sometimes we use the medicines to help improve your cognitive functions. Because usually when you see things or hearing things that's not there, or thought something happened but nothing really happened, it's not really you. It's just the brain perceived things in the wrong way. You know, it's not like people with schizophrenia or bipolar, you know, they're crazy, right? We're not crazy. But we just that our brain perceives things in the wrong way, okay? Because it's not there, but your brain says, oh yeah, it's there. Or hear something that's not there. So if we can give a medicine to improve the cognitive functions, for example, like donepezil or Aricept, Exelon patch, memantine, those things will help improve your cognitive functions, and then the hallucination will go away. And this way, usually, this is based on my own experience only. It is about 3 to 4 weeks after we improve the cognitive functions, medications, then hallucinations go away. So all these things is the option that we can use or in together in combination. Okay, next slide, please. Okay, so this one I'm talking about, I cannot see it.
Health conditions.
Oh, okay. So maybe you can stand here so I can see what I'm saying in there. Am I out of the view? Can I stand here? Yeah, you can. Oh, okay. So maybe you can go this way. All right. So and then some other underlying health conditions and things like that can affect. So just you can go through that, and then this is the cause. Actually, the top one kind of block the RLS, restless leg. It's supposed to say that underlying cause of the restless leg syndrome. Remember that we said that restless leg can cause the sleep problem because you have to move. You cannot, once you feel comfortable in bed, you have to move again. And so we want to look for what is the cause of the restless leg, and then you can treat that. Accordingly, like iron deficiency, give you iron, and if you have diabetes, neuropathy, and thyroid problem, we can treat that. And I don't think that in this audience will be pregnancy. I don't think, but the pregnancy can do that too. And then the treatment is I listed I want you to scan through this. These are the things that can affect the restless leg too. So we have to avoid the medicine that can cause it. And then the treatment, we can use the small dose of the dopamine agonist that can help. Actually, it happened to be used for Parkinson too, so we can use it for both. Sometimes we can use gabapentin, pregabalin. Okay, next one, please. Okay, and this one I'm talking about nocturia. I think the top part of the slide it kind of got blocked because it's the big content, I think. So basically on the top it's supposed to say, okay, now how about sleeping and getting up in the middle of the night because you have to go to the bathroom, what we can do. Okay, this is the top that is blocked by. Okay, this is last weekend I was looking at the literatures and the articles, and I found this review article that is very interesting. So this is the list, the name of the article, and then please go back, go to the next one. Okay, but I don't want to bombard you with all the information, but I just want to show you that there's a lot of medicine that we use to reduce the bladder, to reduce the sensitivity of the bladder, that make you like have to go to urinate all the time. But the one that the cheapest one, insurance cover, the number one to go to by all urologists and primary doctors is oxybutynin, or another name is ditropan. It's very good. The problem is that it blocks the brain too. It blocks the bladder and blocks the brain. The problem with our body is that we had a receptor, right? The term receptor. Receptor is like a switch, and it depends on where the switch we attach to. It will control that. So if the switch attached to the brain, it turns on your brain to work or not work. And if it attached to the bladder, then it can, okay, now go bladder, go to the urinating or not urinating. And so when we want to block that receptor, which is called anticholinergics, is blocking the cholinergic receptor. That is a receptor that present both brain and bladder, and many other places. But it just, we block the bladder, we block the brain. So, and you can see that, I think there's a list of the medicine there. Let's see, donepezil, not donepezil, I mean where'd it go? Oh, this one is another one. Okay, so this one is another blocker. So when we block the bladder, we can block in different, the receptor. Can you go to the next one, which is going to be the next one? Yeah, this is the one that I'm talking about. That also. So that's why it's become a problem. Like the good one is the expensive one, which is the next one. Next slide, please. Oh, that's not in there. Okay. The next one is the Myrbetriq. You have heard of that, Myrbetriq? Yeah, that is kind of very new and then a very expensive one, but that is the one that do not block the brain. So that's why it become a little problem, and we have to work together with the urologist to see which one will go to the brain the least. So the key take-home message from today is that if you go to see your primary doctors or a urologist, and if they want to know what medicine that you can take, make sure that just the bladder cover in general that related to Parkinson, the one that I can help you and recommend on adjustment of medications, and then the next one I will ask Dr. Izzo to help with, and then she will go in more deep detail on how we can treat you and improve your brain functions, and not just the medicine. Or even though we need to do the medicines, she will give you a general idea what kind of options we have, and which one is expensive, which one not expensive, and which one is more practical. Because you know, every time when we want to do something that's great, I say, okay, now insurance doesn't cover. Okay, I have to go with the prioritization. So I asked Dr. Izzo to kind of summarize on something that we can use that will not so much of the problem with the money and insurance. Yes?
Question, I see a lot of reference to chemical treatment. What about the physical condition, exercise?
You mean to help with sleep? Yes. That part I don't know exactly, but what we know is that with the physical exercise and active during the day, then you'll be sleep better at night. But definitely don't exercise just right before you go to bed. Then you cannot sleep. Yeah, but that's part of the sleep hygiene too, because we want to be active during the day. If you sleep too much or nap a lot and inactive, no physical, then you're gonna be not able to sleep at night. And it happened to me too. But I sleep all the time. During the Hurricane Florence, you know, like when we had like a 1 week, nothing to do. I was okay. My mom and dad sit next to me. I'm sitting on the couch, and all of us sleep all day. We don't have anything to do, so we sleep. So definitely physical activity is good so that will help you sleep better at night. So basically the medicine that we use to treat the overactive bladder, we have the two receptors we target. One is the bad one that block the cholinergic acetylcholine, so cholinergic blocking. That is tend not to be good unless something that is not go to the brain. Now two, we work on the alpha adrenergic. I don't want to give you too much lecture, but you know, like sympathetic. Have you heard of sympathetic, parasympathetic? Okay, and they have like a cholinergic is parasympathetic, and then there's the adrenergic, which is more like sympathetic. But then there are two types of adrenergic, which is alpha and the beta. And alpha is like more like constriction, more acting, and then beta is like a losing, like similar to the lungs and the heart as well, because alpha will be more like make the heart beat faster, but the beta will block the slower, like a beta blocker. Have you heard of beta blocker? Yeah, so a beta blocker like propranolol, metoprolol, those types of beta. So toward the bladder, same thing, alpha and beta. So if we want to do something to reduce the bladder functions, we have to block the alpha and activate beta. So those are the medicine that work on different things. So Morbitrix is the beta adrenergic, acting. Yeah, so hopefully it's not too much of the lecture here. You are ready?
So I'm Antoinette, just to introduce myself. Antoinette Izzo. I get to practice in sleep medicine, and I've been doing that since 2006. I started out in pulmonary and sleep, and then morphed into not just sleep, but morphed into sleep medicine, and I love it. It's actually a joy to help people feel better by helping them sleep well, so it's pretty awesome. So, and I just had a wonderful accomplishment. I earned my Doctor of Medical Science through the University of Lynchburg, which was really exciting. I graduated in May, so that's exciting. So it's always wonderful to get educated more and more and get to the top of your field. So that's pretty exciting for me. Thank you. So I think we're still having problems. It's called Novant Health Pulmonary. I actually put cards by the coffee and the snacks up here, and we're on Medical Center Drive. And it's not, of course, it's not just me practicing in sleep. We've got a good team. There are only 2 pulmonologists there who don't actually see sleep patients. They may funnel people into the sleep lab when they need to, but they wouldn't be someone you would see initially for a sleep consult. So we have a team now of, I think we're up to 9 providers. So that's 7 of us who can help with sleep. So we may still be having, and
Just stretch.
I will keep stretching. Speaking of, I can teach y'all something. So there is something that is, it's actually literally called a posterior leg stretch, and it helps with restless leg syndrome. It is something that if you are experiencing issues with balance, you may have to be cautious with, but it's something where you literally stand 2 feet away from the wall or some surface that is steady, not a door, because we don't want someone opening the door when you're leaning on it. What you want to do is you want to put your hands up, and you put them up as far as you can, and then you just lean forward. And what you're doing is leaning forward to feel a stretch in the back of your legs. So, all right, to do that 2 or 3 times a day. And what you want to do when you're stretching is you want to hold a stretch for 10 to 15 seconds as long as you can. If any stretching hurts, you stop it immediately and find out what's making it hurt, because it should not be painful. So that's something to think about adding to your day if you have restless leg syndrome. So you're not quite ready. Okay, so we've already been through that. So Dr. P did an amazing job telling y'all what insomnia is. I agree with her, and so I'm not going to go into the first part of that, but I do want you to know, am I okay? Not yet. I am okay? All right. So we'll go to the second. If you don't mind going to the second slide. All right. So and I see some of that's cut off. We'll get through the actual words though. So what I want you to know is insomnia is very common. It's common for everybody, even in the general population. But in Parkinson's, 30 to 80% of patients with Parkinson's have some sort of insomnia. And like Dr. P said, it can be from a multitude of causes. I'm not going to go through all those things. I do want you to know the research tells us that some of the drugs that are common for Parkinson's disorder, we don't know what effect they have on insomnia. They may make it worse, they may make it better, but you have to take your medications that your neurologist tells you to take. And if you take a new medicine and it seems to cause insomnia, it's just something that you want to have a conversation with your provider about and see if you need to be worked up for insomnia. Then, let's see, so like Dr. P said, insomnia can be a secondary problem, meaning it's caused by something else, like sleep apnea, like restless legs. So the problem with that is I need to see patients to diagnose them with sleep apnea. And so you would be referred over to a sleep specialist or try to make your own appointment to see someone like me to figure out if a sleep study is actually needed. And then there are some questionnaires that you may be asked to answer when you're seeing a sleep specialist or maybe even your neurologist. Some of them are Parkinson's specific and questions about sleep in Parkinson's, and then some of them are to screen out mood disorders. That's what that Beck Depression Scale score is. Because if someone has a mood disorder like depression or anxiety, it's really hard to treat their insomnia without addressing the mood disorder as well. So we'll go to the next slide. So the treatments, so actually the number one treatment for insomnia across the general population is cognitive behavioral therapy for insomnia. And that's a mouthful, so we say CBTI. And all that is it's basically sleep restriction. So it's teaching you to sleep efficiently in bed. When you're awake, you're supposed to get out of bed. When you're sleeping, you're supposed to be in bed. I have simplified it a lot by saying that. So it's actually a 6-week program. Thankfully, the FDA has approved it. So we do have some insurance coverage for that now, which is awesome because it used to cost about $800 to $1,000 out of pocket. So now the insurance coverage is helping us get people into that program. Unfortunately, we lost our in-person psychologist, so it's all done online. But it's been proven to help just as much as the in-person. It's just not tailored to each individual. So that's something that we can do now. So that's exciting. The studies tell us Lunesta, which you may know as Zopiclone, probably Lunesta is the better thing to call it. That's a sleeping pill that acts like a knockout punch. So it really, when you take it, for most people, it makes them feel extremely sleepy pretty quickly unless they've had what's called a high-fat meal at supper time. So the high-fat meal will make it not absorb as well, which would make people feel like it's not effective. But Lunesta is something that, like Dr. P was saying, it's one of those drugs that can cause some dependence. And so we'd rather not have to use it if we don't have to help people sleep. But it is available and has some good studies to help people with Parkinson's sleep better. The other drugs that are newer, like Belsomra, one is called Dayvigo now. Those medicines actually are not knockout punches. So people who are used to taking Ambien, Lunesta, those kinds of drugs that make them just knock out and fall right asleep, when they transition to something like Belsomra, it doesn't make them feel the same, and they say, well, that drug's not working for me. But it is most likely working. It just causes the wakefulness centers in the brain to slow down. So it promotes sleepiness by making you less awake. I hope that makes sense. instead of giving you that knockout punch. So if you do take a medicine like Belsomra, Dayvigo, just give it time. Give it even a couple of weeks to make sure that it is or is not working, and don't expect it to knock you out, because we don't want to do that. When we give people things that are too strong, it can make you too groggy in the night if you did have to get up to go to the bathroom or for any other reason, and you may stumble, and we don't want people falling because, of course, that can cause injury. So then another important thing to talk about is light therapy. In the morning, when we get up and we're exposed to light, by being in a room like this, by walking into the building, by sitting and eating our breakfast in a kitchen that has good windows in it, by going on our patio, our porch, sometime between when sun rises and 9 a.m., it actually helps our brain wake up, and that helps us be more awake throughout the whole day and sleep better at night. And we don't talk enough about that, because in clinic, we try and help people get to, and again, it doesn't need to be in a room. It needs to be sunlight, or they do have little light boxes you can buy on sunlight, and they can be turned on at your breakfast table, stimulate you and make you feel more awake during the day and sleep better at night. Insomnia. And then sleep hygiene and stimulus control. I do want to make sure you know what that means. Sleep hygiene is keeping the room cool, quiet, dark. Stimulus control is staying off the computers, the phone, or 2 of bedtime. It's difficult, and any time you make a change like I'm not going to do electronics for an hour or 2 at bedtime, you want to be at that to see how much it impacts your sleep.
The recording isn't going. Can you check the recording? I have information.
Uh-oh.
The recording's off, but the screens are showing.
On the record problem?
Could be on Zoom, I don't record a thing before it goes through.
This is coming from a Zoom caller. Okay.
I don't record it, someone on their end records it, Tyler records it.
Oh, I see. Sorry to interrupt.
Thank you. We do want people online to be able to see it too, or the virtual to see it too. So we can go to the next slide. So the next topic I want to talk about is excessive daytime sleepiness. Maybe you could move that piece at the top down to the bottom, because if it's at the bottom, it's never going to be in the way. So excessive daytime sleepiness. So a lot of people who have Parkinson's are struggling to stay awake during the day. In fact, we think 20 to 75% of patients are struggling with that. And it does seem to get worse as Parkinson's progresses. So there is a kind of a crescendo of that. So it may not be bad after the initial diagnosis, but it can get worse over time. The way we figure out how sleepy a person is we ask an 8 questionnaire or 8 questions. It's called the Epworth Sleepiness Scale. It's things like, how likely would you be to doze off reading or watching TV? And so we ask those questions to quantify sleepiness so we can figure out how much of an impact it's really having on a person to figure out if they need treatment. So the next slide. So the studies for with Parkinson's patients tell us that caffeine, which is readily available, and we typically all are consuming some portion of caffeine, it may or may not help. So the next slide. Sorry about that. So it should say caffeine. So let me just tell you, so caffeine may or may not help. One thing we do know is there's no FDA-approved amount of caffeine that's safe, but what I want you to know is there's been a lot of studies on caffeine, and we think anything under 200 milligrams, which is most cups of coffee will have like 50 milligrams in them, but anything under 200 milligrams doesn't seem to be excessive amounts of caffeine. When we go over that, sometimes we have something called paradoxical sleepiness, where we're more sleepy than we would be if we had no caffeine at all. So you can just count up how much caffeine you're getting in a day. You can look online and see the caffeine content in your coffee, in most cups of coffee. You can look if you're drinking soda, which we really shouldn't be because it's just sugary, bad stuff. But if you did drink soda or tea, you should add that in. The things we get in chocolate, stuff like that, don't really count much. So have your chocolate, enjoy your chocolate, but not right at bedtime. So then there are other drugs right now, so substances besides caffeine that are actually being studied by really smart researchers to figure out if they will help patients who have Parkinson's with this excessive daytime sleepiness. They're not available yet, but there's hope for the future that we can help people stay awake better with some of these medicines that they're studying. And like Dr. P said, we want to treat those reversible causes of sleepiness, the sleep apnea, restless legs, REM behavior disorder. So next slide. So I want to tell you about, really quickly, sleep-disordered breathing. The most common breathing disorder that people have is called obstructive sleep apnea. And many of us know what that is because many of us know someone who's on a CPAP. So obstructive sleep apnea is a problem where the air doesn't flow into the throat like it should. It's blocked by the tongue or the airway itself collapses. And so 20 to 60% of patients who have Parkinson's actually will have sleep apnea. It's a big high number. Why is it such a range? Because some studies say one number, some say another. That's why I have to give that big range. And so if you're suspected of having sleep apnea, you'll see somebody like me. You'll have a sleep consult, and then me or my colleagues will figure out if you need an in-facility PSG, which is a polysomnogram or sleep study. And that is a big deal because it's away from home, and that can make you have some struggles with your sleep. The problem is the home sleep apnea testing is only good for ruling in sleep apnea. It does not rule it out. That means if we do a home sleep apnea test, it comes back negative for sleep apnea, I have to do the in-facility test. So that just delays getting a person diagnosed. So if I can get people to go into the facility, I'd much rather do that. Plus we monitor for leg movements in the facility too. Remember, restless legs is common. We want to find out if you have that issue as well. Next slide. So the treatments for sleep apnea, like I said, most people are familiar with CPAP. CPAP it's a breathing machine, so it's a mask system attached to a little air pump, and that air pump pressurizes air. It sends it through the tube into the throat, and it holds everything open. It doesn't give people oxygen. It doesn't ventilate them. It holds the throat open so their brain can take over and breathe normal. The BPAP or BiPAP is just two pressures. So I go back. CPAP is one pressure. When you inhale and exhale, it's the same. The BiPAP is two pressures. When you inhale and exhale, they're different pressures, which is more like our natural breathing. So people who don't accept or tolerate CPAP, sometimes we have to use BiPAP. We figure all that out. Patients don't have to figure that out. And then something relatively new is an oral appliance. It is not used much in our area because it doesn't work as well as CPAP and BiPAP does. But in case you've heard of it, it's from a dentist. It goes on the teeth. It keeps the bottom jaw slightly forward. That opens the throat slightly. It only works for mild apnea. And then the studies tell us that weight loss isn't generally helpful for patients who have Parkinson's disorder. So it's not something we tend to recommend unless someone has an excessive amount of calories, BMI above 35, 40, something like that. So you'll hear people in the community say, well, you just need to lose weight to make your sleep apnea go away. And that's not necessarily true. So I do want you to know that that's not something we always recommend. So next slide. So this is the big one, restless legs. So like Dr. P said, it's basically an uncomfortable feeling. It isn't pain for most patients. It's just uncomfortable in the extremities. And believe it or not, it can happen in the arms, even though we call it restless legs. A small portion of patients have it in their arms as well. And so people describe it as discomfort in their arms or legs. And it does happen more frequently when we're sitting and resting. So in the evening it happens more. And like Dr. P said, it's going to cause problems getting to sleep. It doesn't usually wake people up too much at night. It makes them have more trouble getting to sleep. And if we do a sleep study, the in-lab polysomnogram, what we'll see is those periodic limb movements of sleep. So we put these big stickers on the shins in the sleep lab, and they're kind of like EKG leads if you've had an EKG. And those leads tell us when a person's leg moves, and if a person moves, if they're fidgeting and they're wiggling their leg, that's not restless legs. What happens in the sleep is, or going to sleep, is the leg moves and then the brain activity changes. So the movement in the leg is actually waking the person up. That's what's disruptive of sleep. And so that's what we capture on a sleep study. And the one of the causes of it can be, like Dr. P put on her slide, reduction in what's called ferritin, which is the way our body stores iron. And that can be something we can measure with a blood test. So I know it sounds odd, but if you have restless legs, we may do a blood test to check for that ferritin level. And then there's some things that can make you think you have restless legs, but you don't. So things like arthritis pain, cramping in the legs, muscle aches, general muscle aches. So some of those things can make us think, well, I must have restless legs, and you don't. So there are questions that can be asked to kind of mine down to that and figure out if it's restless legs or those other conditions so we can treat appropriately. So like Dr. P put on her slide, we want to stop the offending agents, and she listed those. I'm not going to go over those again. The thing about the iron is a lot of times labs will come back and they'll say your iron and ferritin are normal, but what we know is if they're below a certain level, even though they're normal, we still need to replace that iron because it does impact restless legs for it to be below this level of 50. Sorry, go to the next slide. So I'm going to the next slide on here, and it's not doing that there. Apologies. So there are a few things that can be done besides pharmacologic or medicine, and those are when you sit down to rest in the evening. Remember, that's when restless legs is going to be worse. Pull on some compression socks. They make ones now that zip up, so they're a lot easier to get on. And that gentle squeeze on the back of the legs can actually make a person more comfortable. There's but if that doesn't work for you, just stop it. Then there's some people like heat applied to their legs, so if they'll put a little warm compress or a heating pad on the calves, then and you have to be careful with that. You only leave it on for 20 minutes, and then you take it off for about 40 minutes, and you can put it back on for 20 minutes again while you're sitting, resting, watching TV. Of course, if that doesn't relieve that uncomfortable sensation, just stop it, but it is something that can help. And then we talked about the posterior leg stretch already. The medications, you look at that list of medicines, those are familiar to you because a lot of them are used already in Parkinson's. And so we use them in very small doses in our general population. And so we figured out they did help people with restless legs. And so now we know in your population, they should help with restless legs as well. So the unfortunate thing about some of these drugs, so the Mirapex and the Requip, and even the Nupro to a certain extent, is they can cause something called augmentation, where over time, sometimes people start getting their restless legs symptoms earlier in the day. And so if that ever happened to a person who was being treated for restless legs, we want them to tell us as providers so that we know that's a problem. We will reduce the dose of that drug and start something different. And then, let's see, go to the next slide. So I want you to know there's a difference between restless leg syndrome and periodic limb movements of sleep. So the periodic limb movements of sleep is, it's a problem that we basically are told by a bed partner, whereas restless leg syndrome is something we're told by a patient. So periodic limb movements of sleep happen where the legs are moving, but the patient doesn't feel it. They're not aware of it at night. It doesn't seem to make them have trouble going to sleep, but their partner can't sleep because there's so much movement in the bed. And so it's a problem, but there's no, it's more of a problem for the partner versus the actual patient. And so, and again, it can be the arms too, but most likely the legs. As you can see, it occurs in 4 to 8% of the general population. We don't have those numbers on Parkinson's patients or patients with Parkinson's. And then if we If we did do a sleep study on someone with periodic limb movements, what we would see is that PLMA, that stands for Periodic Limb Movement Arousal Index, meaning we would see their brain move them either from deep sleep to light sleep or light sleep to deep sleep, and then we change the diagnosis to periodic limb movement disorder. Because again, if the partner's feeling it, the patient isn't, and the patient's doing well during the day, not sleepy, feels like they're sleeping well, we don't treat it. If the partner feels it, the patient's not feeling it, but it's a lot, so it's happening a lot to them at night and changing their brain activity, and they have some impairment, then we'll say, now we need to think about some sort of treatment, similar to the restless legs treatments. So next slide. So unfortunately, there's no FDA-approved treatment for the periodic limb movements, but what we do is we just use the same or similar medicines that we use for restless legs. So we use them off-label. That's done in medicine a lot. And then the other thing that can be done if a patient doesn't feel like they're impaired, so they're not sleepy during the day, they say, I'm sleeping all right, this is a partner problem, then we'll say, think about trying to sleep on a different surface. So believe it or not, those hybrid mattresses, foam mattresses, those things can limit the amount of movement a partner is feeling, so they may be a good idea. Sometimes getting twin mattresses, putting the partner doesn't feel it. And then don't forget to limit those stimulants, so things like caffeine. And I left off nicotine, but I wanted to mention it. So of course, we don't really advocate for people to smoke at all. And if you are smoking, if you smoke within a few hours of bedtime, it can increase these movements. So this is something, again, these are big words, circadian rhythm disorder. What does that mean? It's a clock problem. So it's a discrepancy between what the society says you should be, when the society says you should be awake, and when they say you should be asleep, and when you actually are awake and asleep. So it's kind of like if you think back to when people say the baby has their nights and days mixed up. It's like that. So it seems to be worse in our area in the darker months, which we don't have many of, so probably from December through February, it seems to be worse. And again, it's something that we see more in patients who have Parkinson's disorder because of the changes in the brain. It changes the way the clock genes and the way the clock works in the brain. So how do we treat it? That's that good old light therapy again. So it's getting that bright light in the morning hours, again between sunrise and about 9 a.m. And like Dr. P said, moving is important, exercise is important. The time of day of exercise doesn't really matter as much as that you are doing it consistently. And then we used to think melatonin would help us with patients. Sorry, can you go to the next slide? So we used to think melatonin could help us treat patients who had circadian rhythm disorders, but now it doesn't seem to be bearing out in the studies that we have. But someone may try melatonin if they're trying to help you regulate your sleep-wake cycle. So I just wanted to mention that. So then the next slide. So REM behavior disorder, it's like you see there, that smiley face, I meant it. What Dr. P said is right. But the big things are, we see this in a lot of patients who have Parkinson's. Actually, we think that the REM behavior disorder may come first. So we may see that. I may be seeing patients for this dream enactment behavior before they even have a diagnosis of Parkinson's. That does not mean everyone who has dream enactment behavior has a diagnosis of Parkinson's. But it means we really watch closely, and I work with Dr. P. I refer if I suspect that there could be a diagnosis of Parkinson's because they are so closely linked. So that's what the research is telling us now, is that it may be a heralding sign of a problem with Parkinson's or some of the other neurologic disorders. There are a couple more that it can be increased in as well. So when she was talking about the medicines, the first line therapy actually that we use is melatonin, because what we want to do is we want to try something that is going to cause the least harm, because remember the clonazepam, like Dr. P said, it is short-acting and it is going to possibly cause problems with dependency. So if we can use melatonin and it helps people sleep without as much dream enactment, then we are going to lessen the likelihood of injury. So that's why we want to try melatonin first. There have been, anecdotally, I try to get patients to use melatonin that's long-acting. So they have different supplements that you can buy now. They have the immediate release melatonin, and then they have a longer-acting one. The issue with that is, as you know, in the morning, if you get up and you feel hungover, drugged, sleepy, groggy, then you're not going to be able to tolerate the long-acting melatonin. But the short-acting one may not work the way we want it to, because dreams tend to happen, they cluster more in the morning hours. So the longer a person stays asleep, the more we go into dreams. And so we need this drug, whatever we're using, to work as the night goes on, not just at the beginning of the night. So that's why a lot of times I will have people try a longer acting melatonin. One of the common ones is called REM Fresh. One of the warnings about it is to be cautious and not become active unless you have 7 to 8 hours of time in bed. Not necessarily sleep, because we don't always sleep well. We raised our hands when we did and didn't today. So then the second drug that we use is clonazepam, and it does seem to work to help people not stop dreaming, but to help the body be more still. So those dream enactment behaviors, whereas before treatment they may be big movements, flailing the arms, even punching, grabbing at things in the air. Once we treat with the clonazepam, people do seem to tone down their movements. It doesn't always make them stop moving. And one other thing that's important is REM behavior disorder can also cause vocalizations where we're screaming or talking, and none of our treatments, melatonin or clonazepam, will address that. So talking, screaming, I'm sorry, but there's not a lot we can do about that. But the dream enactment behavior, that's what we're focused on. So the other big thing here is safety. So when people are acting out their dreams, they are not aware of what they're doing, and we want them to we don't want them to get hurt, and we also don't want them to hurt their partners. So these next things are really important. So looking around the bedroom, making sure that if there's any sharp corners on anything, that furniture is not near the person who's sleeping. And if there is a sharp corner and you just can't bear to part with that furniture, then you pad it. So you cover it with some sort of padding so that if someone hits it, they're less likely to break open their skin or cause a bruise. So the other things are make sure the environment is safe if a person gets out of bed. Believe it or not, this REM behavior disorder can make people move out of the bed, like even stand up and walk. So we want the windows in the bedroom locked. We want the doors to the house locked, not the doors to the bedroom. So don't lock people in their bedroom. That's not what we want. The other thing is to make sure people, if it's available, you're sleeping on a ground floor. Because if something did happen and a window was thought to be an exit, we want people on the ground floor so that they're hurt a lot less if they somehow were to make it out of the window. And I know that sounds scary, and that's a very rare occurrence. But again, these are the things we want to prevent, is injury from REM behavior disorder. So then, let's see, some people don't really like those padded rails for the bed because we really do move a lot. And then if you need to get up at night, how do you get up if there's a rail there? So it's kind of an afterthought to put the padded rails on the bed. One thing that's pretty common is moving the mattress down to the floor. Issue with that is, we all know how hard it is to get up from a surface like this. So then if we're trying to get up from a low surface, it may be even more difficult unless there's a grab bar or somebody's going to help you out of the bed. So that's something to think about. If you lower the mattress, you have to be able to also be able to get off the mattress to go to the bathroom and get up for the day and that kind of thing. And then the last thing is, it's important, is to remove anything that could be considered a weapon, a knife or anything like that, out of the bedroom so that it's not accidentally used in a dream enactment behavior. So the next slide. So the last thing is, As you all know, as shown by when we raised our hands showing who didn't sleep well last night, these problems with sleep are quite common. And we, like Dr. P said, we want to find the cause. We want to treat that cause. If it is a primary insomnia issue, then we want to use medications, but after we try behavioral therapy. And then we want to all practice the good sleep hygiene, the stimulus control. Don't forget, ask for help. You're not alone if you're having problems sleeping, as you could see by the show of hands earlier. And I do hope you can all sleep well. And now we'll have time for questions.
May I ask a question?
Yes.
So I would like to ask for your expert opinion. For example, when I see my patients and I use something like mirtazapine,
Yes.
trazodone, or even like small dose of nortriptyline or midoptyline, how do you feel about those medicines? You can say everything. Do not insult me. I want to learn from you.
Absolutely. So unfortunately, the research tells us that there is no drug that is safe to use long term, but those drugs are better. So what I mean by that is when we talk about drugs for sleep, everybody thinks, I need Ambien, I need Lunesta, I need those strong drugs, and those actually are causing dependency, they're causing probably some cognitive issues. And so the drugs that you're talking about I'm much more comfortable with those. And a lot of people are on those types of drugs. And so we don't routinely advise people to stop those types of drugs. Yes, ma'am.
What is the maximum amount of melatonin that you suggest your patients use if they want to try melatonin? I've tried up to 20 without having a hangover, and that's about my sweet spot, I think. But I'm wondering, have you seen people go higher than that?
We have, but don't recommend it. So we have seen people go much higher, but I do not recommend that. In fact, in my practice, I recommend people stay at 12 or less. We try to maintain patients between 1 and 3 milligrams, actually. So there is one thing I should have mentioned. Supplements are not regulated by the FDA. And if you get melatonin made by Nature Made or Nature Bounty, whatever, there have been independent tests on those, some of them, and a lot of them don't even have any melatonin in them. So if you can find supplements that have a little, if you can find a supplement that has a little gold seal that says USP, that stands for United States Pharmacopoeia, and what that is they've independently tested that substance, and it has what the label says it has in it. There's not, from what I looked up the last time I looked at it, there was only one melatonin that met that, and it was actually it was about 5 milligrams, so that seems a bit high to me. So what I would say is use a trusted brand if you can't find the USP seal, the gold seal. What that means is the big names tend to put what's in the bottle on the label. The other thing we've learned over time is, I know they're easy to take, gummies are easy to take, but there's a lot of inconsistency, even in a good brand. The gummies, you take one night, it's got 1 milligram, you take one the next night, it's got nothing, because they're not good at getting the right amount in gummies. So it is better to take a tablet or a chewable tablet, but not a gummy.
Thank you.
You're welcome.
And I have a question
Yes.
related to that. So let's say we start taking melatonin tonight.
Yes.
How long we should wait to see if so we don't feel, oh, it's not working yet?
Yes. So I would say 3 to 5 nights, and then make a decision about changing the dose, changing the brand, changing from immediate release to controlled release. Yes, Sandra?
Online question. How would you determine what time to take the melatonin before going to bed?
That's a great question. I should have addressed it. So we want to take melatonin 1 to 3 hours before our target bedtime. So if you think about natural melatonin, your own melatonin in your brain, we are releasing that when the sun goes down. So in the winter months, we're releasing that at 5, 6 p.m. And we're not getting drowsy at 5 or 6. So think about that. That's how you can rationalize some people taking it 3 hours before their target bedtime. That's when it happens to work the best. That also can reduce the hangover effect the next morning. So if you take it not just right at bedtime. Yes, Sandra?
What are your recommendations for PWP when they wake up in the middle of the night or very early in the morning, when you can't get back to sleep?
I don't know what PWP means. What is it? So what are my recommendations for a person with Parkinson's when they wake up at night? That's a great question. So if it's in the middle of the night, probably the best thing to do is actually stay out of bed for a certain amount of time. What I mean by that is, we used to say, wait 30 minutes and then get out of bed. And then we figured out we were making people watch the clock, which is bad. So if you wake up in the night, you go to the bathroom, come back to bed, you're getting frustrated. I can't go back to sleep. This is very aggravating. Get out of bed. So you want to get out of bed. This is something that the cognitive behavioral therapy for insomnia will really help you learn. But you get out of bed and you plan an activity in a space in the living room, in a second bedroom, in an office, where you're doing something quiet, something that doesn't take a lot of effort. You are not doing a chore, so you're not unloading the dishwasher or starting the laundry. You're doing something like reading, journaling, doing a Sudoku puzzle, playing solitaire. Remember, we don't want you on electronics in the night, so it would be better to have an actual book with Sudoku puzzles in it, or a deck of cards, or a book to read, not a Kindle version of a book. And so you do those things until you get drowsy. But that's the key. When you get drowsy, you go back to bed. So you have to, when you feel that sleepiness, go back to bed, because remember, we're trying to train our brain that we sleep in bed and we're awake everywhere else. So that was a good question. Yes, sir?
To me, one of the most dangerous things is at night when you have to urinate. Because, number one, to get up safely, you've got to turn the light on, or you're trying to
Yes,
make
sir.
your way into wherever that bathroom is,
Mm-hmm.
and so forth. And portable urinals do exist,
They do.
and you really have to use those to look at how far you've got to get to the next place. Because to fall in the middle of the night with no light, or waking your partner up because the light's on, et cetera, et cetera. So it's just a point.
So there have been some studies that show low light in the bottom, like at the baseboard, that is basically something you'd have to have a switch to turn it on, but it's like that cabinetry lighting that people put underneath their cabinets. So if there were lights like that, that supposedly helps with that issue. I don't know if a personal light, like a flashlight, would help, because you really need to be able to see well. You're right, because we don't want you falling on anything. Are you asking how much melatonin is available? Like what different brands? There are, it's dozens, and unfortunately, that's the problem. They cannot regulate them. There's no regulation of that kind of substance. So the best long-acting one that we found in our practice is called REM Fresh, R-E-M, and then fresh, like fresh fruit. And then the other brand that we recommend a lot is the Nature Made, because they have a lot of their substances have been, bless you, they have been tested by the USP. Unfortunately, melatonin is not one of those. But since they have a lot of other stuff that's tested, we do trust that brand. So what I should have said before is, if you find a brand of melatonin that works for you, buy it. So don't go changing, oh, this one's on sale, let me get that one instead. Don't do that. Just stick with the one that works for you. Yes?
You said vitamin C helps with the iron retention.
Yes.
How much should you take, and should it be in orange juice, or should it be in a tablet form that you can buy vitamins?
As long as you don't have any problems taking citrus, so some people take medicines that don't allow them to drink certain juices. So as long as you can take the orange juice, it is better to take the iron with a juice instead of taking a supplement with it. But it's just the standard vitamin C supplement. And I apologize, I don't know the actual milligrams. I can figure that out and somehow let y'all know, but it's just the standard supplement of vitamin C. And For women, a lot of times our multivitamins, the premenopause multivitamins, will have iron and vitamin C in them, but the male formulations don't have that. So that's something else to think about. If you're taking a multivitamin, so do be careful of that. Yes, Sandra.
What are your thoughts on CBD at night?
It's not regulated, we can't recommend it. So again, I could be an evil person and say, I want to get rich and I'm going to put this water in this bottle and call it CBD and sell it. If I had good marketing, a lot of people might buy it and I could get rich quick. I would never do that, but unfortunately there's some unscrupulous business practices, so you have to be very careful of things like that. Thankfully, the VA is actually doing some studies on CBD and different substances, and eventually we may be able to recommend some of that stuff, but right now we just don't recommend it. So that's part of the issue, is that excessive daytime sleepiness that can be caused by medicine. If you can't fight through that, we only have a certain amount of sleep we can get in a 24-hour period. And so if you're sleeping during the day, we have to add that on to the sleep you're getting at night, meaning you may not be able to get back to sleep. So I didn't answer the second part of the question, which was if you wake up too early, so not necessarily in the middle of the night, but too early, should you start your day? Yes. So there are some times where you just need to go ahead and start the day with something, again, not chores, but things that are calming, so that if you do happen to somehow miraculously get sleepy, you can go back to bed. The bad news about insomnia is it's the most difficult thing we treat, because we don't have good, safe drugs that make people sleepy enough but don't make them fall down when they try to get up and go to the bathroom. So we either try to knock them out, which again, that sounds crazy, but that's what the things like Ambien and Lunesta do. They just zonk you out. And then the newer drugs, thankfully, like the Belsomra, the Dayvigo, those are just trying to reduce the wakefulness in the brain, not really knocking people out, but making them feel less awake. So it may be that you have to add a substance. It may be that you have to say, so I'm saying it may be that you have to add something to help you sleep through the night better, or it may be that you have to say, if I'm going to sleep 2 hours during the day, then 6 hours is all I'm going to get at night.
Well, if you're concerned about REM sleep for half of it.
And so we're getting REM sleep. You should be getting enough REM sleep if your cumulative 24-hour cycle is somewhere between 7 and 9 hours of sleep. And again, that's day and night. So one thing that could help is filling out a sleep diary. So they have sleep diaries online. You can you can figure out how much time you're actually sleeping.
As I said, I'm very consistent with that cocktail.
Yes.
5.5 hours.
Mm-hmm.
And I can't get back to sleep, and it's 4:30 in the morning.
Yes, sir. And that does feel way too early to start the day, which is why that's why I was saying you want to do something quiet and not disturb the rest of the house if you do have to start your day at that time, but it may be that you need something else to help you sleep longer. Or again, fill out, I really think we don't use sleep diaries enough. They're a really good tool where they have a block for every hour in the day, and if you will just mark off all the times that you sleep, you may notice that you are getting 7 to 9 hours of sleep in a 24-hour period. And again, that's all we can get. So we're not going to be able to give people who are getting their 7 to 9 hours something to make them sleep through the whole night until 6 or 7 in the morning, because they're getting some sleep during the day. So I think a sleep diary could help.
May I ask you, when you were waking up at 4 a.m., what made you wake up?
It feels, after I'm awake, it feels like.
It's not like because you were uncomfortable, because the levodopa wearing off and make you wake up?
It's not.
No, not that.
And I don't have this great need to pee. I have had TERP,
Mm-hmm.
prostate, so I'm not,
Not that kind.
you know, not,
So in this situation, the sleep test not gonna help, right? Because I always kind of prone to look for what make you awake.
I don't think it, so for, if you came to me with this complaint, I literally would send you home with a 2-week sleep diary so that we could see how much time you're actually sleeping, because that's what I need to know so that I can figure out how to address the issue.
Well, see, I would gladly avoid the nap.
Okay,
Can't avoid the nap when it's 95 degrees out.
no. No, you can't. You're right.
In other words, I can't go out for this or walk here or whatever.
No, it's not safe. Don't do that. You're right.
In wintertime, there's only so many bundling up and walks that I can do.
So the unfortunate thing that I'm trying to say though, is if people are getting their 7 to 9 hours of sleep day and night, sometimes that's as good as it gets. I'm sorry. It's so disappointing to tell people that when they're upset about getting up so early, but that sometimes is what happens. Again, I would not know that without that sleep diary, and it's so simple to do. And you literally can fill it out yourself. You just print one off the internet.
My husband has severe orthostasis, so he's not able to do any physical activity, outside of sitting in the wheelchair and trying to do some exercises in the wheelchair. Some days he sleeps the entire day except for meals. So, and I know that he's not getting good sleep because he shouts, he gives speeches in his sleep. We were just out of state and he bolt upright out of bed, reaching for things that aren't there. So, I don't know if any of that stuff would help him. He's stopped taking Mirbetric, as Dr. P said, because it helps, or it lowers his blood pressure. So, we're at a loss.
Is he on anything for sleep?
He takes mirtazapine.
Okay. So again, like we talked about, Dr. P and I both, when people have that dream enactment, a lot of times they need either melatonin or the clonazepam. So it sounds like he's going to need one of those, because that dream enactment behavior, it's not just bad for him, it's bad for you because it awakes. But even if he's,
Otherwise, I wouldn't be able to sleep.
but if he's shouting, you're going to hear that. If he's moving around a lot, you may also hear that, even in another room. So it does sound like he's going to need help with that, with the substance is what I'm saying. The unfortunate thing though is as the Parkinson's progresses and the excessive daytime sleepiness progresses, there are, again, it's times where sometimes we say there's nothing else we can do, but in his case it really does sound like medicine or a supplement could help. Yes?
As an aside, what do you think about eye masks when sleeping at night?
I think if you do not have the ability to shut shades, if we were trying to sleep in here, we would need an eye mask. So they do seem to help us block light. The other thing is, you know how we were talking about we need light to see, to go to the bathroom, etc. So sometimes the bed partner also needs to wear an eye mask so that those other lights, when a person's getting up to go to the bathroom, don't bother them. Have a good night, good day. Yes?
Your recommendation in light therapy for the period of time to get up in the morning and have bright light? What period?
Any time between, so are you asking how long to be exposed to the light?
Right.
About 30 minutes.
30 minutes.
Yes.
I'm still fairly early on to my Parkinson's journey with only 5 years behind me, but what helps me fall back asleep, and I'm thinking of you at 4:30, because I too wake up and, is having my headphones close by and having the app called Buddhify, or there's many others, like this is Buddha, like Buddhify, and listening to Matthew McConaughey read a bedtime story, or whomever, there's a sorting mechanism where you switch it up all the time, but listening to Buddhify helps me fall back asleep every time. I don't even remember the story half the time. Have you tried that?
That specifically, I would not be interested in.
Oh, it has music and other meditations too.
Yeah, I understand.
Okay.
But the concept, working with it is something that would soothe me and
there's something I should teach y'all too. So there is a technique, it's a breathing technique that can help us feel calmer. It lowers our heart rate, it lowers our blood pressure. It's really simple. It's called boxed breathing. So you think of a box, think of a square. So think of 4 sides. And so if you wake up in the night, you can do this for a few minutes and see if it helps you go back to sleep. So what you do is you breathe in for a count of 4, and then you hold the breath for a count of 4, and you picture drawing a box or a square while you're doing this. So you hold the breath in for a count of 4, then you breathe out for a count of 4, and then you hold that empty lung for a count of 4. And we can all do this, no matter if we have orthostasis, any of us should be able to do this. So it's something you can do anytime you feel anxious. And we do feel anxious when we wake up in the night and we don't want to be awake. So it's something to try practicing so that you know what you're doing. It helps you be distracted from being awake. So I do think it's something y'all should practice. So it's boxed breathing. Breathe in for a count of 4, hold it for a count of 4, breathe out for a count of 4, and then hold the empty lung for a count of 4, and just keep repeating that process.
And through the nose and out through the mouth.
Exactly. And then the other thing you can do, a more active thing you can do, is look up on YouTube, look at yoga stretches or poses for sleep. So things that you can do in bed, because sometimes that can also help you get back to sleep. I did not even think of that before, but it's you just go on YouTube and type in the search menu, yoga stretches for sleep to do in bed. So it's things, again, that shouldn't be a problem for patients who have balance issues. It's stuff you do in the bed. So I think is that it? All right. Thank y'all for having me.